So we're going to be talking about endoscopic spine surgery. Here are my disclosures. Nothing's relevant to that. This is like what I find fun. I love doing big wax. I love doing osteotomies. This is what gets me excited. And so what about disc surgery, and why would I consider this? So disc surgery to me is the extra point of spine surgery. Patients come into you. It used to be a 2-yarder. They expect you to hit it every time. You clang one off the uprights. They're pissed. And they're like, why do I still have leg pain? So why would I ever take something that, is pretty good and make it a 35-yarder? And this is how I felt when I first thought about endoscopic surgery. Like, why am I going to take a surgery that I'm okay at and make it challenging? And what are the benefits? And so as we think about adopting new technology, this Gartner hype curve is often something that comes on. And endoscopic surgery has been around for a while. It was first introduced in '96. And I think we're sort of on this rise of adoption. I think a lot of people in the audience are endo-curious, as I was. A lot of people are thinking about, like, should I adopt this? Should I do this? And is it because of marketing? Like, are people going into competitive markets and want to offer something different? Because it's new and innovative, you can put your name on a billboard. You can get Facebook posts. People can look at your social media and like it. Is it because they have better outcomes? Do you have pressure from your peers to be the endoscopic person in your group? Or does it fill a gap? And so when I think about adopting new technology, I want all of these things to be part of the reason that I adopt them, but I really want to fill a gap. And that's when I sort of change practice. And so if we look at the literature, most of the studies that have come out are pretty small and they're pretty early because this is just sort of gaining popularity. And if you look at very small cohorts of patients, open discectomy versus microdiscectomy, they show a difference in pain meds being prescribed on day 1 to day 3. But once you really get past the acute phase, there's not much of a difference. So if you look at ODI, you look at back pain at 6 weeks and at 3 months, there's not a huge difference. So small studies aren't pushing us. If we then look at meta-analysis, well, we have a ton of small studies, let's put them all together. Does it push me towards doing more surgery? And the answer is not really. The outcomes from all of these meta-analyses are essentially the same. People have less back pain early, but by the time you get to 6 weeks and 3 months, there's really no difference. Leg pain is the same. And so what gap does it fill? I practice in Utah, so this is a really big patient. People that practice in my hometown in Pittsburgh, this is average, right? And so the benefit of doing endoscopic spine surgery is what it allows you to do. If you look at a recent NISQIP study, there was almost a 0% infection rate when you do endoscopic spine surgery. That is a really, really big thing in poor diabetics, obese patients, and it minimizes soft tissue damage and the required incision. For me, it's also a challenge, so it's something fun to try to do. When we think about endoscopy, this is a very blurry picture, I apologize. This is what you get when you let PowerPoint try to make a slide for you. There's essentially 2 ways to do it, uniportal versus biportal. And uniportal, essentially your scope is also coupled to your working channel. So you're working through a single scope. You're limited by the size of the scope. The scope tends to be somewhere between 7 and 10 millimeters. It is excellent for disc operations. And it's okay for laminectomies as you get better and better with an endoscope. There's 2 approaches. One is through the foramen, or a transforaminal approach. You can enter the canal if you get very sort of level to the disc space. And the second is interlaminar. And so where do I think these fit in really, really well? And so what I think it's good for, I think it's a perfect operation for a far lateral disc. And so this is a case I did yesterday or 2 days ago. It was a 58-year-old gentleman with right L4 radiculopathy. You can see his right L4 foramen, huge foraminal far lateral disc. Essentially, the way you do a transforaminal endoscopic disc is a Seldinger approach. And so for orthopods who we think 3-dimensionally in X-ray, it's a relatively easy thing. You want to dock your sort of guide wire right at the junction of the superior aspect of the L5 pedicle. And I use neuromonitoring for this. I use free run EMG to make sure I'm not getting close to the nerve. And so essentially I dock a guide wire right on that medial aspect of the pedicle. You then switch it for a sort of a guide wire over a needle, and then you drop a switching stick and you essentially pound it along the medial aspect of the pedicle right into the canal, and then you drop your cannula. And what you want to see when you do this is essentially you want to see that curve of the pedicle going into the superior articular facet. You can see that sort of roughened up bone bleeding on the right side of the screen. And if you see that curve from the pedicle to your superior articular facet, you're kind of home. And before you know it, you're right on top of the disc. I was pretty skeptical at first, and I thought the anatomy would be quite confusing, and it is the first couple you do. But then you sort of get a feel for where you are and how to use an endoscope, and it becomes more straightforward. If you remove that flavum that you can see the traversing nerve root. If you sort of work north of what this picture is showing, you can often see the exiting nerve root. And this guy did extremely well for now. He's 2 days out, but we'll see what happens. Nothing ruins surgery like follow-up, but we'll see where it goes. But for me, this is a great indication to pick up an endoscopy rather than doing a Wiltse approach, rather than moving muscle or even a tube. The reason I do this over a tube is because I don't have to futz. Like, I am right there at that time, and I'm looking through a camera with great visualization at three-dimensional anatomy. The interlaminar space also is relatively sort of easy to adopt. When I first started doing this, I really tried to cherry pick cases. I wanted soft discs. I wanted discs that push the S1 nerve root out of the way. So the hardest part when you're doing an interlaminar disc is you dock on the back of that 5 lamina. You can get sort of a outlet view of your interlaminar space, as you can see on the far right image, and you have a pretty large space to work through. But the challenging thing is, when you only have one hand, is to move it in such a way that you can mobilize things and also feel at the same time. And so when that S1 nerve root is already being pushed out of the way and you can fall onto a soft disc, as soon as you're through the flavum, it's pretty easy. And again, once you get more facile, and this is not my picture, but you can see very, very clearly the anatomy that you see open. And so it takes a while. There's definitely a learning curve, but once you get better and better, it is pretty easy to see what you see open through a smaller incision. But when it goes badly, it can go badly. So this was a BMI 65 patient who was sent to me because now I'm doing some endoscopic surgery. That's the downside of picking it up. You start to get all the best patients. And she was miserable. She had terrible S1 radiculopathy. It had been there for forever, so I got a CT scan to see if the disc was soft. What I didn't really look closely at was all the ligamentum calcified, which, there's this super bright white thing right next to the facet. And so as I went in, as soon as I went through the flavum, I started seeing nerve roots. And when you get durotomies with a new technique, it is very discouraging. I had rootlets herniating out through the scope. And I said, "Oh shit, Brandon, why did you ask me to pick this up?" And so here I am converting an endoscopic surgery to an open. I'm now in a cavern. I'm packing nerve roots back into the canal. I'm doing a partial medial facetectomy. She ended up doing fine. Like, it's amazing how resilient the nerve roots are. But these are the cases that when you're picking up a new technique, a new surgery, you're like, why would I ever go back to do it again? Like, it's a very disheartening thing. But I still did it. This was about 6 months ago. I just saw her for a 6-month follow-up, and she's doing great. So what do I like about endoscopic? It's so easy to get there. Once you're there, it's great visualization. The scopes are very high quality. It looks like open anatomy. You're just doing it through a smaller lens. It's a low risk of infection and possibly expanded surgical indications. So I can do bigger patients. I feel comfortable doing patients with BMI, with A1Cs that are slightly less well controlled than an open surgery or a tube surgery. But I think there's limited feel, and what I don't like is it's harder to assess, have I done an adequate decompression? There just aren't a lot of tools for tactile feedback, which is what I use when I do an open surgery. Where is endoscopy going? And I haven't picked this up, but biportal endoscopy is sort of much more natural fit to the way that we do things, right? You're using 2 hands, and it's essentially MIS surgery with a camera and a working hand. So rather than a tube and a scope, you're putting a camera in and you're using your other hand as a surgical instrument. And people will argue, like, this is great. We can actually enter a disc space. We can ensure that we do great disc prep. We can have bleeding bone. And this is really, really nice. Now, is it 1 incision? No. People that are doing this now make 6 incisions on the back, and they're putting tiny holes everywhere to achieve the goals of surgery, putting a separate hole lateral to get a cage in. But, it is less soft tissue destructive. What are the limitations to doing this? Well, it's the size of your cannula if you're using uniportal. So really, you can't put a cage in bigger than about 9 millimeters because it has to go through a 10 millimeter hole. When you're biportal, you can make a separate incision. You can use a second working channel to get in a bigger cage. And companies are coming out with newer implants that are quite expensive, but they're also very good, and they're filling the disc space. And so in preliminary studies, like, you can achieve an indirect decompression, you can get lordosis through an endoscope. And so I would say that biportal endoscopy is doing everything that MIS is doing, just with a different lens. Are the outcomes any different? Well, not yet. Short-term benefits for endo TLIF over VAS back, again, very short-term, but there's no long-term difference between the groups. When you're doing this, you have a slightly longer operative time because it's new and there's a learning curve. And so, and there's no real difference in complications or fusion rates. But again, these are small studies. Even though it's a meta-analysis, it's very few patients. So in my mind, what are the benefits to the patient? Well, for a microdisc, it's less soft tissue damage. But what I really want is something where I can get people back to sport, back to activity right away. I still have an annular hole. I still protect them, so it really doesn't change my postoperative course. In a laminectomy, though, when I do it open, I do shut them down for a little while to allow their muscles to heal. If I were to progress to using an endoscope, I'd probably let them get back to doing things pretty quickly. And for a fusion, less soft tissue destruction, questionable lower rates of ASD. I think that's sort of debated in the literature, but I think we're moving towards a trend of that. And questionable shorter hospital stays and can be done as an outpatient. So what are the limitations? Well, there is a huge learning curve. I've probably done about 20, 25 cases, and every case I'm still like, why am I doing this? But then you sort of figure it out, and it gets easier and easier. Severely collapsed discs become a challenge, but again, you can use pedicle screws, you can use distractors, you can do things to get in. Multi-level surgery, I still don't think a lot of endoscopic surgeons will do a 1 to 5 laminectomy. Like, it just takes a fairly long time. You can unzip a spine open in 2 hours versus spending an hour at every level doing an endoscopic surgery is probably too much. And we don't have clear evidence that it's better in the long term. So in conclusions, your indications are similar to MIS surgery. You just have a different lens of getting there. There's an endoscopic learning curve, but it's once you're comfortable, it has similar efficacy as well as in achieving your goals of surgery. Companies are coming on the market because this is hot, and we're getting better instruments, we're getting better scopes. We're starting to use endoscopic spine surgery as its own thing rather than adopting endoscopic instruments to do spine. And finally, there are still no differences in long-term outcomes yet.